I'm going to be contributing a bit of the pharmacist perspective here, but I practice at Vanderbilt, and we are fortunate enough to have a formal multidisciplinary nutrition support team, which is really great because we are able to work closely with our colleagues. But I think, Christan has showed clearly that this patient and patients like these are going to have a benefit from starting nutrition therapy early. But what do you do when you get pushback from providers, from consulting teams about PN? And I would say that for my entire career, the number one thing that I have heard from clinicians and providers who are hesitant to initiate PN is that it causes infections and these patients are already sick. We don't want to make things worse. And usually they are still repeating things that they heard in their training, sometimes 20, 30, maybe 40 years ago. And, I feel like in every aspect of medicine and healthcare, we know that when there's newer, better evidence, you pivot and you move towards that. But for some reason, these things regarding PN are just very difficult to get information out. I think the people in this room, I think we all get it, but how do you take this information back to your colleagues and people who are outside of ASPEN and show them, actual contemporary data? So I'm going to kind of walk through that today. We'll focus a bit on really, what we hear in practice are the big concerns. And these are known complications of PN, right? We're not saying that none of these things ever happen, but I think we have better strategies for management for all of these things now. So I'm going to start first with clinical outcomes. So the first two trials, and I'm not going to read every single thing on these tables, so if you have the handout, please don't be alarmed. But we do have two pretty large trials that were done after the year 2000. So if you read the newer set of ASPEN guidelines, one of the big changes was that they didn't consider data that was published prior to the year 2000. And the reason for that is because it's very difficult to compare ICU care in general, if you think about things. So a lot of the studies that led earlier recommendations about holding PN for 7 to 10 days were published with data from the 70s and 80s. We didn't have standard precautions until 1996. We didn't have central line care bundles until the year 2000. We didn't have, optimal glycemic control. The Vandenberg trials with tight control, and then the nice sugar trials where we found that, a little bit looser, but definitely not letting your patients have blood sugars of 400 and 500. Those were published in, 2000 to 2009. So ICU practice is very different. The other thing that is different is the way we make parenteral nutrition now. So we have much more rigorous standards in the United States and worldwide for how these things are compounded. I am from Alabama, and I trained initially at a rural hospital where the pharmacist would tell me tales about how they used to keep an ashtray on top of the IV hood, so because you could smoke in the IV room while you were working. Okay, we don't do that anymore. We have, when you know better, you do better, and so we are definitely doing a lot better now. So that's why these trials that are newer are very important. Okay, so we've got the calories trial, which was done in 2014. This was a multi-center trial of 33 ICUs in England. It had over 2,000 patients, which I think for a nutrition trial is, very large. And what they looked at here were infectious and clinical outcomes in patients who received early PN versus those who received early enteral nutrition. And there was no difference in 30-day mortality or infections. Although I will say, and kind of the theme with all of these studies is that these patients were in the ICU, but their severity of illness scores were really not that high. So these were not the sickest patients. We also have in 2018 the Nuturia 2 trial, which was done at multiple ICUs in France. And this was another trial that, again, showed no difference in mortality, infections, ventilator-associated pneumonia, bacteremia, or central line infections. Not surprisingly, they did see more GI-related ADRs or adverse effects in the tube feeding group. I will say this trial specifically looked at patients who were sick enough to be both intubated and receiving vasopressors. And if you look, as a pharmacist, I always want to know, well, what was the dose of the vasopressors? These were pretty high doses. I would say in many ICUs, a lot of clinicians would not feel comfortable feeding these patients at all at the level of vasopressor doses that they were receiving. So it's not, out of line that they saw more GI adverse effects. And so I think what's important here is not necessarily that PN was beneficial, it's that it wasn't different. So if we hear from our colleagues that, well, PN causes infections, you can't start this, we did not see this in large, well-designed trials with contemporary ICU practices. But let's look at early PN versus standard of care. So this could be, versus IV fluids and transition to tube feeds or oral diets. The first study I'm going to talk about here is the PANIC trial. And again, this is a very large study, and that's going to come up later because this study continues to be used in meta-analyses, and there are a lot of significant methodological flaws with this study. So what they looked at was early PN, which they defined as patients receiving 20% IV dextrose for the first 2 days, and then they initiated parenteral nutrition on day 3. Versus late PN who received 5% dextrose for the first 7 days and then were transitioned to PN. And so what they saw in this trial were increased infections and longer ICU stays with early PN. So this looks bad, right? So we are definitely thinking that parenteral nutrition causes infections. We've got this really large randomized controlled trial. But you have to really pay attention to the details. There are a lot of caveats with this trial. So the first is this 20% dextrose. So the ICU length of stay for many patients, it was 4 days in the early PN group versus 3 in the standard care group. So some of the patients never even got parenteral nutrition. They only received this very high dextrose load. If they did receive it, they could have been overfed. These patients were also predominantly cardiac surgery patients with very low severity of illness. And so essentially what we have here is a trial that is in an ICU, but it's patients who are probably very unlikely to benefit from nutrition anyway, and they didn't. So we do have this data, but it's really not that useful. There was another study done in 2013 in New Zealand and Australia, and they saw different outcomes when they had, I would say, a more robust clinical design up front. There were actually improved outcomes with early PN in this group, shorter time on the ventilator, less muscle wasting, and less fat loss with the patients who received parenteral nutrition. But there were no difference in major clinical outcomes, so no difference in infections, length of stay, or mortality. And this patient population is a bit unique because it did include more surgical patients. And as Christan mentioned, we have a lot of data with medical ICU patients in the nutrition field, and we really need data in other populations. And we also mentioned a bit about using more supplemental PN, and that is something that I think is a bit more controversial. In the ASPEN guidelines that were published at the end of 2021, they state that there's really no benefit to initiating supplemental PN in patients who are not tolerating enteral feeds prior to day 7. But the caveat of that, so that's what makes it into the table, and that's what people are going to quote back at you. But if you read underneath that, they say, except in malnourished patients, and this should be evaluated on a case-by-case basis, which is also what we see in the ASPEN guidelines. Because the trials that looked at this generally are not conducted in malnourished patients. So we have a few trials here that looked at supplemental PN. Some do show a benefit, like the Heidegger trial from 2013. There was a lower incidence of nosocomial infections. The Allingstrup trial from 2017 didn't see a difference with them, but again, receiving PN didn't cause infections. These patients didn't do worse, maybe they didn't do better, but also are we studying it in the correct group? A few more trials came out in 2017 and 2018. Unsurprisingly, patients who receive supplemental PN are going to be more likely to achieve their nutritional targets, but again, no difference in outcomes. All right, so I've got a few more. These are the newest trials that have come out. And the first one was the Metaburger's group, where they did see that patients who received supplemental PN had a trend towards less muscle mass loss, but this wasn't statistically significant. But I do think that's hypothesis generating and something we can look at more. In 2022, there was a trial that came out of China that was at 11 hospitals. This was not an ICU-specific trial, but it was kind of a unique patient population, patients who had had major abdominal surgeries, but again, not an ICU-specific trial. They actually saw a decrease in nosocomial infections in the patients that received supplemental PN, so actually a benefit in this patient population. And there was recently a study that came out earlier this year, and it is a smaller trial, but I think that this is really the direction that we need to be going as we're thinking about what kind of trial designs we need to answer the questions that we have. So they enrolled older adults, so they defined that as adults who were 60 or older, who were considered to be nutritionally at risk. So they either had to have an NRS score of at least 3, or I think they could use the modified Nutrix scale. But these were people that they expected to be in the ICU for a significant period of time, so they expected them to be in the ICU for at least a week, and who were not receiving goal enteral nutrition by day 3. And what they saw was that there was a decreased duration of mechanical ventilation and ICU length of stay with patients who received supplemental PN. They also measured diaphragm thickness, and that was improved, and we know that that is something that could help potentially get patients off the ventilator. Again, this is a hypothesis. It's a smaller trial, but something that we could go towards, and there was no difference in infection rates. So again, I think if we look at this data in the patients that we need it in, I feel pretty reasonably comfortable as a clinician that I know how to treat a 60-year-old man with a BMI of 25 to 30 in the medical ICU, because almost every trial, that is the target patient that we're enrolling. And the reason for that is because, again, it's not a knock to the authors. That's going to be the largest group that we have to look at, and it's going to be the easiest to conduct enrollment. But we sort of have the answers to a lot of those questions. I do want to bring up, just again, coming back to infections, a recent review and meta-analysis that came out. We always get questions on our team about bloodstream infections. Even if patients already have a central line, sometimes the patients already have bacteremia. And so I think there's this concern that maybe the bags come up from pharmacy and they already have bacteria and things in them. They definitely don't. But this was a really interesting meta-analysis. It did look at the newer data from 2000 to 2024. And they didn't find a difference in patients who received enteral nutrition versus enteral nutrition with parenteral nutrition in patients in the ICU. So there was no difference in any of the major clinical outcomes like mortality, ICU length of stay, hospital length of stay, duration on the vent, or respiratory infections. But there was an increase in bloodstream infections, and that really got my attention because that's not what we've seen with these other well-designed clinical trials. So I thought, well, what trials did they look at for this? We know there were 14 studies in the meta-analysis. So you have to go to the supplemental. This is not in there, easily available for you. But you can see that Caesar, a panic study that I mentioned earlier, the one with all the methodological flaws, it carried 91% of the weight for this recommendation because it is such a large trial. So even though we know that it's not a great trial and that there are a lot of limitations with it, it's still going to come up in meta-analyses if it's included, and it's going to carry a lot of weight towards this. So I personally, as a clinician, would take this with a huge grain of salt and say, yes, you may have this abstract that has this data, but let me tell you why that data is flawed. So as I mentioned, what's missing in these studies? We need to study nutrition in patients who are likely to benefit, and that is going to be our malnourished patients. And as Christian has alluded to, you don't have to be underweight to be malnourished. But that's something I think we really need to educate our colleagues. We need diverse patient populations, different types of ICUs, different ethnicities, different weights. We have, a lot of data on that one core group, but what do we do with everybody else? So look around your ICU. If you're reading trials, think about whether those trials and the patient populations are similar to the patients that you're looking at every day. And again, non-medical ICU, I'm a burn surgery pharmacist, so I obviously have a lot of bias towards that, but I really want to know especially in the surgical populations and surgical subsets, what we should be doing. Okay, so clinical perspectives, things that you can take back. PN, if managed well with contemporary practices, does not cause infections. We have strong data to support that. The old data just really, it's hard to get past that, but we have to keep pushing and educating our colleagues, and also kind of removing our own bias with that, and to really look at what the data is showing. And I think you have to advocate for your patients. And so we have better data now, the CT scan data and those type of things, to identify patients who are malnourished. And if you think this is the right treatment for them, don't be afraid to be told no. I mean, obviously you don't want to argue and have negative interactions with your team, but you can advocate for your patients in a professional way. And one of the ways I do that as a pharmacist is with data, because it's hard to argue with that. Okay, so what about lipids and patient outcomes? We also get a lot of questions about this. We have requests to not give lipids because lipids cause liver failure. They cause infections. You will have started the PN and it has been infusing for 12 hours and the patient has an LFT bump and they think it is the PN causing it in those 2 hours. It's not. But I think also there is just not as much awareness about the different lipids that we have now. So for a long time, the only lipid product available in the United States was 100% soybean oil. But since 2016 or so, we've had other products that are available in the US. We have a 2-oil blend and a 4-oil blend. And these still have some soybean oil because it's a great source of essential fatty acids. But they also have olive oil, which is considered to be immune neutral. There is a 4-oil product that also has a component of fish oil, which could have some anti-inflammatory properties in certain patient populations. We do have the 100% fish oil product that is generally used in pediatric patients. I'm not going to focus on that today, but we do have other lipids available now, and the ASPEN guidelines state that there is no difference between 100% soybean oil lipids and later generation lipids. But there again has been more data that has come out that I think really do highlight the need to switch to later generation lipids. And I will say, with this data, it's not perfect. No data is perfect. A lot of this comes from European studies where they have different lipid products that are not available in the United States, and they can be dosed differently. So there are a lot of caveats, but there was a retrospective study that came out in 2026 that showed no difference in infections with a mixed oil lipid versus 100% soybean oil lipid. No difference in infections or antibiotic days or mortality, but the mixed oil lipid group did have shorter antibiotic duration and a lower AST to ALT ratio, so some potential liver benefits there. There have also been a few large network analyses and meta-analysis that have looked at different strategies with lipids, and they have found that fish oil containing lipids could decrease infection risk and some other outcomes like length of stay. With the olive oil lipids, those could decrease the risk of infection and sepsis. But I think the big thing to really highlight here, as I said, because it's difficult to compare products that are available internationally and those that are not, is that the group that performed the worst was soybean oil. And so if you take anything away from that, I think, we're still getting more evidence and we're still doing trials to look to see what the optimal lipid and what the optimal lipid dosing may be. But the group that is performing the worst consistently in the trials is going to be 100% soybean oil because it does have those pro-inflammatory mediators. Okay, so I'm just going to do a quick kind of summary of the guidelines here. So as I mentioned, ASPEN says there's no difference between enteral and parenteral nutrition in the first week, and they recommend against supplemental PN in the first week because there's no benefit until after 7 days. But we know that that is only in well-nourished patients. Malnourished patients are not included in that recommendation. The other thing with EN versus PN, obviously, if you can use enteral nutrition, that is going to be easier, it's cheaper. There are a lot of benefits from that, but I think what this recommendation tells me as a clinician that I don't need to be scared to use parenteral nutrition in patients where it is indicated, even in that first week. And the ASPEN guidelines, which are a bit newer, kind of say the same thing. Use enteral if you can use parenteral. But they recommend considering supplemental PN earlier. They said the optimal time is unknown, consider it on a patient-by-patient basis, but it's likely between days 4 to 7. For lipids, the ASPEN guidelines say that there's no difference, and that you can use, basically any lipid that you want. But the data that was considered for that is older, and I think there is newer data. If we look at our European colleagues, they say that there is potentially benefit with fish oil or olive oil containing lipids, and it's recommended to consider a blend of fatty acids. I would say, though, one thing to note about the ASPEN guidelines is that the word soy appears one time in the entire document. So alternative and later generation lipids have been available in Europe for a very long time, and most clinicians are much more comfortable using them. They have moved away from using 100% soybean oil. So I think our European counterparts have moved on from that question. They're working on other things now, where in the United States, I think we're behind and we're still asking, well, what about, can we use soybean oil? And I think the emerging data indicate that we should be moving away from that practice. All right, so key takeaways. We've got newer data. We should read it. Emerging data indicate that soybean oil may not be as beneficial, especially in high-risk patient groups like our ICU patients, like the one here, and people who are going to be on long-term PN, which we'll talk about in just a few minutes. The data that we have available for lipids is not necessarily comparable with the products in the United States, so you do want to look at that closely. And really, we need more data. We need data with the products that we have in the US and in different patient populations. So my advice, if you've got high-risk patients like the one we've presented, there's no reason to hold PN for 7 days. Another thing that we talked a little bit about supplemental PN is as you're starting, you may be able to use multi-chamber bags. These are not going to be a perfect fit for every patient, but especially when you're just trying to get something going. If you're starting PN and maybe you get a consult later in the day, there are newer formulations of these and they may be beneficial. But if your patients have highly specific fluid and electrolyte needs, they're likely going to require custom PN. All right, I'm just going to touch briefly on glycemic control. That was one of the things I had mentioned that was a bit different with our previous practices, is that we are a lot better at glycemic control than we used to be. We have pretty good targets. These have not changed in the last 10 or 15 years, but it is still important to be mindful of them. We'd like patients to be, I would say the highest you would want is 180. There are some ICU subsets that may benefit from tighter glycemic control, but definitely not extremely tight glycemic control. One of the things we're seeing a lot of data coming out now is about glycemic variability also. So we're trying to figure out how we can control this without having huge spikes that we treat with sliding scale insulin, and the patient comes, down really hard. So trying to maintain good glycemic control that's a bit more consistent across the board. Patients can be hyperglycemic for a variety of reasons, but you should be monitoring this in your ICU patients because it does lead to increased risk of infection, longer ICU stays, and increased mortality rates. So things that we can do to make sure that we're managing PN appropriately is make sure that your goals are appropriate. If you have indirect calorimetry, that is the gold standard. I would love to have that. We do not have that at my center, unfortunately. But we do reevaluate our patients to make sure that we're not overfeeding them. If you can optimize, especially if you're using a later generation lipid, you can push that dose of the lipids higher so you can give less dextrose. There are various strategies for adding insulin into the PN, and you may have to use a combination of that with sliding scale with basal insulin. Continuous IV insulin infusions are recommended by the FCCM guidelines. That's going to only be in your ICU patients. All right, and then lastly, I'll just touch briefly on micronutrient deficiencies. And so I think, again, this is something that our European colleagues, they have really robust micronutrient guidelines that we do not have in the US. I think there has long been a thought that you can't evaluate micronutrient abnormalities in critically ill patients because they have high degrees of inflammation and that affects your levels. But as we have patients who are sicker and are receiving more aggressive therapies like renal replacement therapy, or coming in with malabsorptive conditions, rapid weight loss, those type of things, we are seeing these. So these things can worsen critical illness, and they can also increase your risk of infection. So we can see deficiencies of all of the B vitamins, copper, selenium, zinc. There is data available where you can look to see how much a CRP affects your micronutrients. And, unfortunately, there's not like a great formula where you can correct for this, but it does give you some guidance. So I would say, especially in the inpatient setting, if you're ordering micronutrient levels, you should always get a CRP, and it needs to be done at the same time. So, if your patient, you get levels today, or if you get a CRP today and then levels tomorrow, but your patient went to the operating room last night, that CRP is going to be very different just because of the degree of inflammation. We see a lot of patients now who are on continuous renal replacement therapy for longer periods of time. I help take care of a lot of transplant patients who may be on CRT for weeks. And they have, very rapid depletion of copper, B vitamins, and vitamin C. So that needs to be at least supplemented, but likely also repleted in these patients as well. So this is just some kind of a comparison of what we have in our combination trace element product here in the United States. So I think another thing to think about, especially with like short bowel patients who are going to have altered absorption long-term as well, is that you need to be thinking about whether you should check micronutrients. If it's a patient who was really well-nourished and you don't think they're at high nutrition risk, you probably don't need to worry about checking those levels. But otherwise, you should. You do want to think about when you order them, you want to order a full panel because these things do not occur in silos. Most patients have multiple micronutrient deficiencies and get that CRP. When should you repeat levels? And it really depends on the level of deficiency and how fast you can get your levels back. At our institution, we can usually get copper and zinc back within 24 to 48 hours. So we are able to check that a little bit more frequently. If it takes a week for it to come back in your ICU or your institution, you kind of need to build that in when you're thinking about making adjustments. All right, and as you're doing this, you may wonder, can I put all of these micronutrient things in the bag? And the answer to that is maybe, maybe not. There are some great references that are cited in the paper about compatibility and stability and what concentrations of things. But one of the things you may be able to do is do a 2-in-1 where you can give other things on the side. But as patients prep for home, we generally do prefer the total nutrient admixtures. And if you're adding a lot of things to that, you can have more compatibility and stability concerns. All right, so key takeaways here. PN is not associated with infections in ICU patients. Obviously, if the gut works, we want to use it, but don't be afraid of PN and make sure that you're educating your team so that they don't have to be afraid of it either. We need more research. We need better research. And then again, just, advocate for your patients with appropriate therapies. That includes PN, that includes EN when it's appropriate, and for micronutrients.
Okay, so back to our gentleman in the ICU. He had a prolonged course requiring continuous renal replacement therapy, prolonged mechanical ventilation, but he was extubated on day 8. The CRT was weaned on ICU day 12. The RD has followed along and reassesses for malnutrition ICU day 13 before the patient transfers from the floor. We did repeat body composition measurements. Prior to extubation, we snuck in one more metabolic cart, so I was able to have the MREE. And we were feeding that, but I did reduce the protein once the CRT weaned to make sure hopefully his kidneys would recover. And we have moderate malnutrition based on his muscle loss, and he now has some mild fat stores, but we were meeting his energy intakes. And this is an actual quadricep measurement serially for this type of patient, where we see a 44% quadricep loss during a 3-week hospital stay. So these patients are losing a significant amount with little changes to their adipose tissue.